Yeah. Okay. Hello, everybody. My name is Dr. Rawal, and I'm going to be talking to you today about a subject that I'm very excited about. Hopefully, you'll be too. And hopefully, you guys can all see our screen okay. So I was kind of inspired to give this talk based on a really great grand rounds that we had a couple months ago in medicine from Dr. Kingery about high value care in general. So it got me thinking about what it is that we do in endocrinology to kind of fit into this concept of high value care, what we've already learned, what we already do, and what things we could possibly do better. So I appreciate you guys indulging me as we talk about this subject. And I really appreciate anyone's input. I think this is something that should be very interactive because we all have, points to bring and experiences to bring and how we can improve high value care for our patients. So getting right started, I have no conflicts of interest. Today, I hope to talk about these learning points. So basically defining what value-based care is, high value care versus low value care, and provide some general examples. I'd like to talk about what impacts value-based care has on our healthcare system and identify examples of high and low value care testing specific to endocrinology and how to navigate this discussion with patients and order the best set of tests and imaging to benefit the patients overall. So what is value-based care? So the value of something in healthcare is basically defined by the cost of a healthcare outcome over the cost of achieving that outcome. So for example, I'll use this example throughout the lecture. So knee replacement, what is the healthcare outcome for the patient, for the physician, for future visits, for future falls and injuries related to it versus the cost of doing that knee replacement in terms of the equipment, the physician experience, the surgeon experience, et cetera. And that's how we determine what the value of a healthcare intervention has. What's important, I think, of today's discussion is that we should focus more on the value of a healthcare outcome related to what matters to patients. A lot of times, for the same example, we think about how it's going to value the overall system, cost, et cetera. But using the knee replacement example, a physician or a surgeon might be worried about what is the cost of the procedure and what is going to be the range of motion of that joint afterwards. But a patient's wondering, will I be able to walk up the stairs to do my laundry? Will I be able to carry my grandchildren around? And that's really what we need to find out from our patients is what is it that they value most related to their health conditions? And is it worth the cost of doing it in terms of the patient? So value-based healthcare has a couple essential elements, and I like this figure because it sums it up pretty well. So one is that we should reduce costs. So in the US in 2022, we spent about $13 trillion on healthcare, averaging out to about $13,000 per person if everyone in the States had a healthcare condition. And so we should really think about reducing costs overall by being more productive, working on things that are sustainable, cost effective, and comparatively effective. We should also really think about our patient experience. So what is the level of satisfaction? What are the outcomes? Are things safe? And then thinking about population health overall. So risk management through pooling. An example of this is in OB-GYN services whenever you're managing perinatal antenatal care. The OB-GYN physicians get paid for the lump experience of visits, all 13 or 14 visits, rather than at each visit for each test they order. And that kind of provides incentives to physicians to provide continuity and higher quality care and assume the risk of that care for that patient. And then doing things that are preventive in nature. So thinking about downstream costs of not treating a condition or diagnosing a condition early or preventing a condition, and things that are socioeconomically impactful. So that being said, how do we know what low value care is? So firstly, low value care is ineffective. So example in endocrinology is treatment of older patients that have subclinical hypothyroidism with levothyroxine. All the studies that we've done have shown it doesn't really improve any symptomatology, morbidity, or anything of that nature. So giving them levothyroxine to improve their biochemical thyroid function is ineffective overall and something that we don't usually do. Low value care is inefficient. So, for example, someone that has very well controlled type 2 diabetes is on only non-hypoglycemic causing medications. We don't tell them to check their sugar 4 times a day. It's in excess of what needs to be done, and it's not going to change our management. So it's inefficient. And low value care is unwanted. So, if a patient's diagnosed with a micro PTC and we offer aggressive treatment and radioactive iodine, and that's not really in line with the patient's life expectancy or their values, that's unwanted care. And we should avoid things that fall into that category. So then what's high value care? This is a little bit harder to define in that sense, but an acronym that helps is STEEP. And it really you know, irks me that this figure doesn't have it in that order of that acronym. But firstly, for S is safety. So high value care is safe, and that's based on evidence, trials, and goes along with our principle as physicians to do no harm. High value care is timely, and this includes scheduling patients for visits, scheduling interventions, getting back to them with results, providing timely and efficient care in the clinic. These are things that are a little bit harder to do sometimes and maybe need to maybe require coordination on multiple levels, but something that's part of high value care for sure. High value care is efficient, it's effective, and it's equitable. And then lastly, patient-centered, and most importantly. So those are things that we should think about when providing care. Does it follow and fit into this STEEP acronym? So the terminology and the concept of value-based care really started in the 60s, and that came to light because in that time the healthcare model was mainly fee for service. So there was no incentive for a physician to not order a bunch of tests and imaging and a bunch of medications because they were getting paid the more things they did. Not that they just did it like that, but really now that we've switched to this value-based care and we're looking at compensation based on outcomes, we really think a little more carefully about what things we order, what medications, how it fits into a patient's life, and rather than ordering everything. And that fee-for-service model really caused a lot of healthcare costs in our country as well. So that was another big impetus for it. In the 70s, and the term Health Maintenance Organization, or HMO, was introduced by Dr. Paul Elwood. And basically, he wanted to contain costs, and he focused mainly on primary care, preventive medicine, including annual exams, screenings, immunizations, and things that are going to reduce downstream costs. In 73, this became an act in the States. And then in 82, they started doing Medicare C via TEFRA, and it's now called Medicare Advantage. And this basically authorized the use of Medicare funds for private HMO plans, but this model actually reduced hospital stays by almost 17% compared to when we were doing fee for service. Unfortunately, in the 90s, the HMOs kind of collapsed. We went back to fee for service a little bit. But then in 2006, two physicians wrote a book called Redefining Healthcare and coined the term value-based care. And that was Dr. Michael Porter and Dr. Olmsted Teesberg. And then in 2010, the Affordable Care Act kind of fit into this and continued this to provide value-based care to those that otherwise would not be eligible for private insurance. So fitting into that equitable category of high value care. To further this, the American Board of Internal Medicine Foundation started a campaign in 2014 called Choosing Wisely, and I'm sure a lot of you are familiar with it and what their goals were. But basically, they started this campaign over multiple countries to identify practices that we were using and testing and medications and different areas of healthcare along all specialties to determine if they were really value-based and if it was unwanted or ineffective or wasting money. And did this across all specialties. So they reviewed over 700 tests and treatments in 30 plus countries. Unfortunately, in 2017, they kind of closed down after doing all this review. But I think their mission is something that we should keep in mind and continue. And I'm going to share some of their guidelines that they came up with in partnership with other societies today and how that's influenced our practice today. So What are some of the drivers of low value care testing? So, Choosing Wisely did a physician survey in 2013 before they started their pilot program. And they asked a couple questions, which are very interesting. So, first, they asked 600 physicians, do you think the frequency of unnecessary tests and procedures in the healthcare system is a problem, not a problem, very serious problem? And more than half people, 44% and 29%, felt like it was a problem, a serious problem. When they asked how often they order a test or a procedure that they think is unnecessary in their own practice, surprisingly, 24% said a couple times a month, 17% said once a week, and 20% said several times a week, and 10% said every day, tests that are unnecessary. And they said, how often do patients follow your advice and avoid a test or procedure that you feel is unnecessary? And I like this one because about a third of the time, a little more than a third of the time, physicians said almost always or always. And a third of the time, they said often. So this goes back to the power we have as the provider to educate our patients and guide them along their way, keeping their preferences in mind. But what we say matters. Being up to date, understanding the patient's preferences, working together as a team is going to be really important and actually can help us reduce unnecessary testing in a lot of cases. In your own practice, is this the reason you sometimes end up ordering an unnecessary test or procedure? 52% said they do it because of malpractice concerns, 36% just to be safe, 30% to reassure themselves and get more information, 28% because patients insist on it, 23% because they want to keep patients happy. So there's a theme here. 13% feel like the patient should be the one to make the decision, a lot of times justification is not science-based or evidence-based, so that's something to keep in mind as well. This physician, Daniel Morgan, and his colleagues came up with a couple other thoughts behind the drivers of low value care. And so one broad area is the culture of healthcare consumption. So consumerism, what's available on the media. I saw this video on TikTok about if I, do this exercise, it will cure my thyroid, et cetera. So that whole area is a big part of why we sometimes order unnecessary tests or are asked to order certain testing or do certain things that may not be evidence-based or value-based. Patient factors and experiences that drive this include their prior health experiences, whether themselves or their families, their own health literacy, numeracy, and education. The culture of professional medicine also sometimes drives low value care decisions. There's a big emphasis and value placed on finding answers, certainty, getting that final diagnosis. Along with that, a lot of us feel uncomfortable with admitting that we're not quite sure and we don't have an answer and we don't want to miss a diagnosis. Um, so those are some factors that maybe make us order extra testing that may not be necessary. And then clinician attitudes and beliefs. So we may have some personal biases about how things should be treated or worked up. We may have had past experiences with other patients with the same condition. So we're focused in a certain way, or we think this is the way to do it based on this other experience. And then fear of litigation is another concern for some physicians. The practice environment also will influence this. So financial incentives for the amount of procedures, patients, testing you do. What your group does as a norm also will influence this. So if everyone in the group does things this way, then that's the way you're probably going to do it, or you'll feel pressured to do it in that way. And lastly, the patient-provider relationship will affect this. How you speak to your patient and how you guys get along. If there's a concordance of your culture, race, language, gender, that can influence testing and your conversation, treatment of a patient. So these are things to keep in mind. Not all of these things are within our own personal control. A lot of them are multi-level, but the things that we can control, our own biases, our, tunnel vision when treating patients that have had the same condition as prior patients, our personal attitudes and beliefs can be examined and try to leave them at the door when we enter a room to provide, this value-based care based on best evidence, best practices, and that STEEP acronym. So what are the impacts of value-based care on the health system? Why should we care? So value-based care can benefit us in 5 different ways. One, for patients, it's going to lower costs for their healthcare and it's going to improve their outcomes overall. The more educated our patient, the better for us, in my opinion. It will benefit providers because your patients will have better satisfaction with you. That means better adherence to visits, possibly. They're going to listen to you and have more open discussions with you in the future and a better overall relationship. You're going to have more efficient care in your own practice. It's going to benefit payers. So stronger cost control, reduced risks of procedures, helps payers in the long term, if not in the short term. It helps suppliers and helps society. So reduced healthcare spending frees up those funds for other things, and overall better health of our nation is important. All right, so let's get to the fun stuff. So again, thank you for indulging me. Some of this are my own personal um, bugaboos, I'd say, or little things that I looked into to see what's the evidence behind it, what to do. But a lot of these things are practices from the Choosing Wisely campaign and from Endocrine Society and USPSTF that may seem like things, oh, I already do this, this is old news, but we do this because of these value-based care initiatives. So it's important to remember where we came from and think about things that we can still change. So let's talk thyroid. So thyroid antibodies. So let's talk thyroid peroxidase versus thyrotropin receptor antibodies. So thyroid peroxidase antibody and thyroglobulin, an example of high value care in using these is to check them to establish an etiology of primary hypothyroidism or hyperthyroidism, as many patients with Graves' disease also have a positive TPO antibody, about 70–80%. And it kind of tells us it may not change our management. We may levothyroxine, the LT4 is the treatment for hypothyroidism in most cases, but it may guide us on whether we need to screen for comorbid autoimmune conditions and help to identify the cause of other symptoms a patient may be having. Low value care related to thyroid peroxidase antibody is trending a TPO antibody level or repeating it once it's already been positive. And studies have proven this because the degree of thyroid peroxidase elevation does not have any correlation with the severity of illness, nor does it alter your management course relating to your thyroid hormone dose per se. That's based on your thyroid levels themselves. On the other side, thyrotropin receptor antibodies. The high value care example there is checking these levels in a patient with hyperthyroidism to establish the etiology of their thyroid toxicosis. And also, repeating a TRAB level does have high value. Studies have shown that after 6 months of using a thionamide, if their TRAB level is still greater than 10 international units per liter, this may predict a poor chance of remission and a high chance of relapse. So you may choose to continue thionamide longer. You may choose to refer the patient for definitive care and have discussions about that with them. So surgery or radioactive iodine. So that guides your overall treatment course. Measurements of thyroid hormone levels. So what we've learned from Choosing Wisely is that there's not really a role for checking serum T3 in a patient with hypothyroidism that's been treated with levothyroxine. So it shouldn't be used to guide therapy once they've started treatment. And this was assessed by Choosing Wisely. Basically, they wanted to reduce the use of T3 among providers when treating hypothyroidism. So they initiated this best practice alert that would pop up in their EMR anytime someone would order a T3 on a patient that was also on levothyroxine. And they would have to click a box saying, yes, I want to order this before proceeding. So after doing this, before doing it, they looked at a six-week period in these centers, and about 162 times per 10,000 patients per week, people were ordering T3 in hypothyroid patients on levothyroxine. But after putting up this alert that kind of just like popped up on their screen, this reduced by about 44%. So a pretty significant reduction, but not perfect. And so the conclusion of this study was, that although our National Society guidelines, Endo Society, has recommended against ordering serum T3 while monitoring patients with hypothyroidism, these tests are still frequently ordered. So, they urge people to consider putting this alert in their EMR whenever patients are being treated with hypothyroidism to ask, do you really want to order this T3? And maybe we could reduce how often it's done. So our system does not have that, which would be something interesting to maybe implement for us. Next one in thyroid, the use of levothyroxine to improve symptoms in biochemically euthyroid patients. Okay. So this was looked at the ATA Task Force on Thyroid Hormone Replacement in 2014. And their recommendation is strongly against the use of levothyroxine to treat patients who have nonspecific symptoms and normal biochemical indices of thyroid function, because no role exists for levothyroxine in the situation. This is a strong recommendation with high quality evidence. Nonetheless, this is still something that, is commonly seen in multiple settings, not in our practice, but has commonly seen. So this is an example of a low value intervention that we should work harder to educate patients and other providers about to reduce it. Thyroid function testing in patients that have treatment with immunotherapy. So we've learned in the recent years that immunotherapy for metastatic cancers and solid cancers has been amazing and has had great outcomes on cancer treatment and mortality and morbidity. However, for endocrinology, it means a lot of endocrine dysfunction. And so we can see hypothyroidism, hyperthyroidism in patients treated with immunotherapy. Um, Oftentimes, these immunotherapeutic options are given every 2 to 3 weeks. And so every time there's a visit for that, they get their TSH is checked. So every 2 to 3 weeks, their TSH gets checked and checked and checked. But there's no free T4 ordered and there's no reflex TSH to T4 ordered. So based on best evidence and what we know about these thyroid hormone assays, TSH really takes about 4 to 6 weeks to reflect a true change. And immunotherapy can also be associated with central hypothyroidism or hypophysitis, not just primary hypothyroidism. So that would be reflected by a free T4, which is not often the first test that's ordered. It's only ordered if the TSH is abnormal in these cases a lot of times. So looking at this, there was a study done in 2022 comparing patients that had pre-existing hypothyroidism and started immunotherapy versus patients that never had thyroid disease that developed it de novo. And this was done by endocrinologists. And basically, they did a retrospective study of these patients over 9 years at multiple centers. And they did identify actually 48 de novo primary hypothyroid cases and 12 de novo hypophysitis cases. So this, again, emphasizes the importance of free T4 measurement because that would be missed by TSH. So that is ineffective care, which is low value. And then they concluded that it's reasonable to check TFTs every 4 weeks and actually to space it out to every 12 weeks after week 20 of treatment with immunotherapy. And so this is something that, in endocrinology, maybe we could advise patients on if we're seeing them being treated for these conditions. And hopefully that will spread along to their other providers and we can reduce the testing for TSH frequency. We can also encourage them to check free T4 when they do check. Thyroid ultrasound is another area where we've made some improvements in quality care. So the USPSTF has recommended against routine screening for thyroid cancer using thyroid ultrasound. And Choosing Wisely recommends against ordering thyroid ultrasounds in patients with abnormal thyroid function, but no palpable abnormality on exam. However, a study of tertiary care centers in 2020 found that almost half of thyroid ultrasounds were performed for the reasons mentioned above. So, not for any proven indication. So this is another area where we could potentially improve. Another thing that came from Choosing Wisely was the recommendation about remnant ablation in patients with lower intermediate risk differentiated thyroid cancer. So based on the 2015 ATA recommendation, they're encouraging us that if a patient has a low risk or any intermediate risk differentiated thyroid cancer, that we should use a lower activity of radioactive iodine, 30 or less, for that reason, as opposed to the higher dose that we use in patients with higher risk thyroid cancer or more nodal disease. And that was a strong recommendation with high quality evidence. Let's talk diabetes now. So less here, actually, surprisingly, from what I found, but still we've learned a lot through high value and value-based care. So first is this study in 2012, which influences our inpatient diabetes management, as well as, of course, other trials that are very popular, USPS, US, well, I forgot the acronym now, but our inpatient diabetes management and our big UK trials. Thank you. So basically here they looked at the level of glycemic control and outcomes in ICU patients. So should we keep their glucose levels between 140 to 200, or should we aim for 80 to 110? And what does that mean? Are they going to have improved outcomes with tighter glycemic control? And of course, anticlimactic now, but we all know that tight glycemic control actually has worse outcomes, longer length of stay, increased risk of severe hypoglycemia. And so we recommend more loose targets in our critically ill patients for that reason. But this is something that was not common practice before and that we learned through examining our practices. All right. And relating it back to money, so they also concluded in the study that intensive monitoring in the ICU would cost 2 hours of nursing personnel time for a given patient in a day. So 2 hours a day on one patient, plus $182,000 per year, plus $58,000 in supplies per year, if they did that for every patient in the ICU. So these costs add up for sure. And then now I want to bring it around to a website that I think everyone should check out, which Dr. Kingery introduced us to during his lecture, and that's the nnt.com. So this is the number needed to treat.com, and you can plug in, a bunch of different things and see actually a summary of the studies and what is the number needed to treat for certain effects, harms, benefits of medications, testing, etc. And so when you go to this site, they're going to have a rating system. So green means it's the best you can get. That's definitely strong evidence supporting it. It's cost effective, high value care. Yellow means we need more studies, but it's an okay thing. Red means there may be equal benefit and harm. So, kind of have a patient discussion and really think about it. And black means please don't proceed, Okay. And there's no clear benefit here. So let's talk about SGLT2 inhibitors and GLP-1 receptor agonists. So these are rated green on nnt.com. Benefits in NNT. So this is an example of what it will pop up for you. So SGLT2 inhibitors. So how many times was death prevented? What's the NNT? And you can do it in terms of NNT or percent. So this is the number needed to treat. For a high-risk person, so I would assume that's uncontrolled diabetes, history of heart disease, obesity, etc., 1 in 38 is the number needed to treat to prevent death. And someone that's low risk, so very well-controlled diabetes, no heart disease, it's 1 in 100. As far as heart attack prevented, it's 1 in 71 for someone high risk, which was surprising because that's one of the main things we think about for prescribing it is risk of MI, risk of hospitalization for MI and MACE. So 1 in 71 for someone that's high risk and 1 in 143 for someone that's low risk to prevent a heart attack. No one was helped as far as stroke prevention in the studies that they reviewed. 1 in 40 people was helped as far as preventing end-stage kidney disease, and 1 in 333 in low-risk patients to prevent end-stage kidney disease. So definitely a kidney indication there for high risk, definitely. And then average weight loss for SGLT2 inhibitors was 2 kilograms in the trials that they examined. And it shows you all the references and what studies they did involve. So if you're wondering if there's newer stuff that maybe they didn't include in there, take it with a grain of salt, but it will show you everything transparently on the website. GLP-1 receptor agonist, same thing. It's going to tell you all of these things. So high-risk patients, 1 in 59 is the number to prevent death. Low-risk patients, it's 1 in 125, etc. Average weight loss, 1.5 kilograms on the bottom. When it comes to these medications versus metformin, there was actually no difference in death, heart attack, stroke, or end-stage kidney disease between SGLT2 inhibitors and GLP-1s when comparing them against metformin. They were both beneficial compared to metformin. And then harms as well, they show you that too. It's kind of a lacking table, but 1 in 7 experienced a genital infection with SGLT2 inhibitors. 1 in 17 had a severe GI event with the GLP-1 receptor agonist. So they didn't study a lot of the adverse events, but these are the major harms that were identified and that they studied on the site. All right, another diabetes recommendation regarding high value care is what we talked about earlier. So SMBG measurements, not the same frequency of testing benefits all patients. So, counsel your patients on how often they should check, depending on their level of glycemic control. And we could reduce costs that way, reduce time, and be more efficient. All right, male repro and sexual health. So one of my favorite, yes. So Dr. Sabai said testosterone, you got it. So what is the recommendation for using testosterone for age-related low testosterone in adult men? And this is an ACP guideline. So this is a very common consult we get in endocrine clinic, and they did study it. So let's go over it. So they wanted to see if testosterone treatment, whether intradermal or intramuscular or transdermal, benefited certain parameters in men with age-related low testosterone. Um, so this does not include, pathologies of primary testicular failure, hypogonadism due to surgeries, etc. This is just natural age-related low testosterone. And basically, they looked at these parameters. They looked at global sexual function, erectile function, physical function in self-reported measures, self-reported physical function as far as performance, and then quality of life. And starting with global sexual function, they had moderate certainty of evidence. And they said that global sexual function may increase with testosterone treatment, whether IM or transdermal, compared to placebo, from 0.23 to 0.46. Erectile function did also improve with testosterone treatment. Physical function and quality of life were not so clear. So physical function as far as self-reported measures across the 0.0, no benefit either way, no clear benefit. Performance measures, objective measures were a little bit better, but not significantly with testosterone. And quality of life actually got worse on testosterone in this study. So that was a little bit interesting. But these are all low quality, meaning there's no evidence that these things improved. As far as adverse cardiac events, they were very similar in both, so that's considered low quality evidence that testosterone can reduce the risk of cardiac event. There was moderate certainty evidence that they had similar rates of serious adverse events, placebo versus testosterone, so no increase in that. No significant increase in prostate cancer, but the data was insufficient and not powered to study this. And mortality, same thing. The data was not powered to study it, so insufficient evidence. So the recommendations, therefore, are as follows. One, that clinicians can consider a discussion to initiate testosterone in men with age-related low testosterone if they have sexual dysfunction and they want to improve their sexual function. So you should discuss their benefit, their preferences, the harm, the cost, the mode of administration, etc. Because they did have some small improvements in sexual functioning with testosterone. But they said that we should evaluate this every 12 months and periodically thereafter. And if those symptoms are not improving, we should consider stopping testosterone. So I think that's a very important thing. That's a harder discussion to have, but something that is recommended that we do. They also recommend that we consider IM versus transdermal because of cost. So they estimated about $156 per year for intramuscular testosterone versus $2,100 per year for transdermal. So, that goes into the efficient and costly kind of aspect of value-based care. So kind of recommend intradermal or intramuscular administration instead. And then they recommended that we do not give testosterone to improve energy, vitality, physical function, or cognition. So none of these parameters improve with testosterone. And I think this is the most common complaint that patients have about these kind of symptoms, but evidence is lacking that testosterone will actually benefit them. All right, pituitary. So the example I found here was about prolactin. And, the recommendation was made that we should not continue to monitor prolactin measurements during pregnancy because pregnancy is a high estrogen state, which will increase prolactin levels. There's no clear relationship between how much it should or shouldn't increase. So creating more testing anxiety, more cost of testing, et cetera, unnecessary maybe treatments for patients. So it's something that we no longer do. Again, it seems like common sense, but before 2011, it wasn't so common sense. So something we've learned. All right, vitamin D. This is another favorite. So should we check vitamin D levels? Who should get vitamin D levels checked? Does the vitamin D level actually influence any health outcomes? So this is the USPSTF recommendation about vitamin D and calcium supplements to prevent fractures. And this is in community dwelling adults. So that's important to note also is the population that's being studied. So basically, what they found was a little bit anticlimactic. In men and premenopausal women, they had no recommendation because there wasn't really enough evidence. So, should we supplement check levels? Probably not, but maybe we don't know. Um, they found that more than 400 units of vitamin D or more than 1,000 milligrams of calcium in postmenopausal women, they didn't have enough evidence to really recommend against or for. But they did find that you should not, if you're going to supplement patients like postmenopausal women, you should recommend against less than 400 units of vitamin D and against less than 1,000 milligrams of calcium. So actually, I usually tell patients to take a Tums. So I am not following this recommendation adequately. So it's something that I've changed that they should take 2 Tums or maybe a little bit more. So more than 1,000 milligrams of calcium, and that will actually have a benefit to them, and that's been studied. Other relevant recommendations related to vitamin D, they recommend against giving vitamin D supplementation to prevent falls in community dwelling adults. So vitamin D level does not associate with increased risk of falls. They conclude that we don't have enough evidence to assess the benefits and harms of screening for vitamin D in asymptomatic adults. So the test for vitamin D in Quest Lab is about $250 per episode. So that's for 25 hydroxy vitamin D. So if a patient asks you to check their vitamin D level and you're not monitoring osteoporosis therapy, they're not someone that is high risk for vitamin D deficiency, you're not doing a hypocalcemia workup, then maybe a discussion you can have with your patient rather than just talking about the cost is telling them to take a supplement and how much they should expect to take and review their dietary intake and work on it that way rather than checking a level every visit or maybe space apart how often you check a level. So here's the NNT summary for vitamin D. I told you you can put anything in there and it's going to give you some things. So vitamin D for preventing fractures is black. So do not recommend. No fractures were prevented with vitamin D supplementation in studies, and actually 1 in 36 people had harm, so kidney stones, kidney damage from excessive vitamin D supplementation. Vitamin D supplementation for preventing fractures in elderly institutional adults is green. So 1 in 36 people will have prevention of hip fracture with vitamin D supplementation, and only 1 in 36, same as the other study, would have harm. So we have to balance that. Yeah, so this one, green, is for institutionalized elderly, so 65 or older, living in a nursing home, LTAC. Yeah, versus community dwelling. Yeah, yeah. All right, so all of this in mind, and there are more I can think of, but I'd keep you here forever. But all of this in mind, so how do we actually de-implement our low value practices? What do we do to change how we do things? One thing, firstly, is to identify and eliminate things that cause harm. So I think as healthcare in US, we've done a really good job of this. There's not much that happens in medicine these days that clearly just causes harm and we just do it. So this is a given. Identify and eliminate practices with no benefit. This is a little harder and something we have to think about every day. So is it really going to change anything if I check that TPO antibody again? Probably not. Identify practices that have conflicted results or untested practices or lack evidence. So try to find evidence behind what you're doing, and that might change the way you do it. If there's no evidence, then have a discussion with the patient and make sure it's not causing harm, it's not overly costly, etc. Talk to your patients about value-based care. So including them in discussion is important, I think, especially helping them to understand why you may or may not recommend certain things. Remember that STEEP acronym. Remember what high value care should look like. So safe, timely, efficient, equitable, patient-centered. I lost an E in there. Consider using reflexive testing when possible. So for example, being TSH with reflex-free T4. So don't order both tests simultaneously if you don't have to. If one's abnormal, it'll go to the other. And that applies to situations where applicable. But same thing with why in medicine we do a urinalysis with a reflex culture. So if it's abnormal, the culture will be there, but we're not doing cultures on every patient. And that will eliminate costs as well. How do we discuss value-based care with patients? So this is a little difficult at times. And, I think what was mentioned in the last grand rounds when Dr. Kingery was talking about this is, knowing the right, having a sense that certain patients may not like to participate in this discussion or might perceive biases on part of the physician when talking about these things. So if you come right out to a patient and say, vitamin D test costs $250, like let's not do it. Some patients may understand what you're trying to get at, and some patients might take offense, to that. So having a discussion that's whole rounded and everything is important, and knowing how to approach that. So I'm going to ask for input from all of you in a minute about how you think you would approach discussing value-based care with your patient. But first thing I think I would recommend is to listen. Really think about your patient's preferences. What is their bottom line? When they're asking you to test something that you think is not necessary, what is it they're afraid of? And what is it they hope will change by doing the test and finding that answer? Maybe you can find another solution. So what is really their concern or their hope? Explain your rationale, explain things to patients. A lot of times, I'm surprised by, I shouldn't say surprised, I'm pleasantly surprised by how well patients respond to just an explanation of why we do things the way we do. Why didn't I check their T3 level? Okay, let me draw you this picture. Let me tell you about this. And they're like, oh, okay, that makes sense. So explain to them and take the time to do so. Set clear expectations. So this particularly goes with preventive care and screening that we do, in my opinion. So, tell patients once a year at least, I'm going to check your cholesterol, your urine microalbumin if you have diabetes. These are things I'm going to check once a year and is recommended check once a year. Once a year, I expect you to have an eye exam. So set those expectations and help them understand why you're not doing those tests every visit. Because some patients want to get blood work and results every visit to see how they're doing, but sometimes that's not necessary. So giving them those guidelines of how you recommend that you proceed. Using terminology like patient-focused care or quality-focused care can also help, because that's really what it should be. It should be based on the patient and their preferences and their outcomes, and that's what value-based care is. Provide alternatives. So if not wanting to do this thing, can we do this? Example would be MRIs for low back pain. So this is a classic example of low value care in internal medicine and primary care. So, we shouldn't order an MRI in everyone that has low back pain. A lot of these things are musculoskeletal. MRI is not going to yield anything to change our management or our recommendations in most cases. So if patient says, hey, you need to get an MRI, my back hurts, say, okay, here's what I think is happening. This is your exam. These are the most common things. These are symptoms. If it were something serious, I would expect these symptoms. How about we try a period of this analgesia regimen, physical therapy, these exercises, and in 2 weeks, if you don't feel it better, we'll circle back and have another conversation. So provide alternatives and let a patient know what to expect and when you're going to follow up with them, and tell them what are the warning symptoms that would trigger you to then do the MRI. All right, so any thoughts from the audience about how you would discuss value-based care or about anything that we talked about today? Yeah, Dr. Krish.
This is very timely. Thank you so much, Malika.
Mhm.
Especially ACGME requires that fellows and staff know value-based care and when they send the survey. So this sort of satisfies that for endocrinology. One of the things we did, Dr. Levinson can attest to that. This was when I was a junior faculty at the VA. Is many of the primary care physicians at that time, VA had the EMR. We didn't have it here. Would send referrals because they would order 125. They'd order and then they would do it. They didn't know which one to do. So in the checkbox, when somebody orders 125, it would say it's only specific to pulmonary or renal or endocrinology.
Yeah.
Say that there.
Yeah.
And then that year, I was told by the lab, when we added that box, pop-up box, they saved $40,000 with 125.
Oh my goodness.
That was what I heard from them. So that was a real big situation.
Yeah.
The second thing is us endocrine, like vitamin D, because our patients are pre-selected like a bias because we see them either for fatigue or osteopenia or, many of those things. So we may end up doing more. But as you all know, when we click the vitamin D, Medicare, Medicaid, it doesn't let you order. You have to go through that whole thing of trying to find a diagnosis that fits vitamin D.
Yeah.
The same with A1C.
Yeah.
So certainly there are some in place, but when we're in such a rush, the time is the biggest challenge. Sit down, explain to patient when they come in with these things. Sometimes it's harder, but the more you do it, end of the day, it's cost effective and saving dollars, which could be used elsewhere.
Yeah, so for the audience virtually, Dr. Krishnasamy mentioned an intervention where it used to be that every time a vitamin D was ordered, it was the 125 that was being ordered. So they developed a kind of checkbox that you have to click saying that checking 125 vitamin D is restricted to certain specialties. So it curbed that practice and they saved over $40,000 with that. So that is definitely high value care in that sense. And then talking about how our patients are kind of pre-selected to check vitamin D levels, but we have to then put in a proper diagnosis in order for insurance to pay for it. Otherwise, it won't let us order it. Sorry, that's my alarm, so I don't talk too much. And then, I think a big part of this that we didn't talk about, this is just testing, but value-based care is multiple things. So timely, efficient, comes to your point of our visits being very quick and a lot of issues. And that's something that's not going to change on an individual level, but we as physicians and other providers have to kind of lobby for the proper time to adequately assess patients and have the follow-up to address these things. A lot of times we may feel like we can't address everything. So we say, today we're going to talk about these things that are a little bit more pressing. I want you to come back in 3 weeks and see me again and do this. But we forget sometimes that the patient pays every time. One patient told me pays like $100 every time they come see me. So I can't bring him back every 2 weeks. That's not efficient. It's not cost effective. So that's something that has to be a larger change that hopefully will happen. Any other questions from the audience or thoughts about this and value-based care in your practice? Okay. Okay, yeah, thank you. Let me stop sharing. Here's the code as well for those back home. Okay. And I'll put it in the chat box too. All right. Yes, thank you. So Keisha says that she encourages patients to have conversations with their providers and come to a decision together. So I think that's something that we all want at the end of the day. We want to feel like we're on the same page. So from our standpoint, we learn the evidence, we learn about costs, and what we need to do better is learn about our patients and their preferences. And then from the patient standpoint, kind of trust in us. So understanding why we're saying it. Any other?
Hi, Malika.
Hello.
Hey, Malika. Hey, this is Swapna Dev here. So great talk. I think it's very necessary, especially because of the cost of care that gets driven up so much because of some practices. One thing which can be done, which is kind of probably not something that we as physicians would like, but I think just like how the charts get audited for and this could be just an internal audit, but how they get audited for coding, etc. There could be physician audits for unnecessary testing. Because I'm known of some physicians who, when I am cross-covering or so, and
oh, I think we lost you. Let's see if we can get
just like how the body shapes or 21 again or so will order like a whole battery of 100 tests. I mean, of course, it's never that bad, but even just ordering, for instance, if you are seeing somebody in the hospital for hyperthyroidism or thyroid storm and you have a free T4 that's 6, and the next day you follow up for your rounds, you don't need to order a TSH. I mean, the TSH is going to be suppressed. Just get another free T4. You're saving money every time, every day for the next 3-4 days. So just stuff
Absolutely.
like that. So some internal
That
audits
was,
like that, maybe by peers or by would be an option to curb some of these
yeah,
habits.
I think that would be mixed reaction, but I definitely agree that, there has to be some accountability in some form. On a positive note, I had a patient come today after seeing a metabolic clinic to get compounded semaglutide. They happened to do her prolactin first level for some reason, and I think we're going to diagnose a prolactinoma. So, hey, sometimes things work out. But I agree, the trending of TSH in patients. Another thing I didn't get to mention, I'll just put it on here since I'm the speaker and I have a captive audience here in that sense that, using steroids preoperatively in every patient in the hospital, especially those with diabetes, and not notifying endocrinology. So a lot of hyperglycemia after like an EGD, they don't need 8 milligrams of Dex before, or if they do, maybe they can be a checkbox that says, hey, this patient's being treated for diabetes. Do you want to alter their insulin regimen or something like that? So some kind of EMR alert. So I appreciate that suggestion, Dr. Dio. Thanks.
Thanks for the talk.
Yeah.
I'll just say that I'm not sure that the cost is something that is really being considered any. Okay, and the FDA, they don't you're on an FDA committee, costs are never mentioned, doesn't make any. The only question is there a significant effect? And the size of the effect, I don't know how you determine what's a clinically significant effect, but it.
Yeah, I think.
And it, on this slide, I don't know.
I think you're right. I personally didn't think about cost too much in certain things, vitamin D being my go-to today, until I got a bill for a vitamin D from my physician. And I was like, hey, whoops, I'm ordering this all the time. I need to think about it. A lot of our patients can't afford to pay that. And then where does the cost go? Who pays for it at the end of the day? But Dr. Levinson said that maybe we're not keeping costs in the forefront. One thing I would say, though, example is the GLP-1s and tirzepatide. So many studies have been done. They're the talk of everybody, even layperson, TikTok, everything. Everyone's talking about them for whatever reason. But now certain insurances are saying you can't prescribe it in a patient that's obese. So you can't do Zepbound, and you can't do Wegovy in someone that's obese without diabetes unless they also have heart disease. So insurance is thinking about cost.
No,
And they're,
I
know,
appreciate there are
yeah.
some, but these are probably more related to insurance
Yeah,
than anything else because they don't want to pay off.
agreed.
And
Medicare.
so, yeah, if you have a number needed to treat and that also has a confidence interval. So if the number needed to treat is 20, then that means you're helping 2.5% of the patients.
Yeah,
On the average, because the confidence interval, which with the number needed to treat, calculated as the reciprocal of the absolute risk reduction, confidence interval is not necessarily symmetrical. It could be the confidence interval for that 20 is 4 to 100.
mhm,
Often people don't even look at the confidence interval. That might be you're only helping one person in 100.
it's true.
Again, it depends, like you were mentioning, the how high the risk might be.
Mhm.
That's another factor you can add in. But then you start to get very, very complicated on what you're dealing with. And I'd say nobody really has a good idea about what's going on.
Yeah, and then,
With much of what's going on there.
yeah, agreed. That's why, they say quality-based care is easy to define and hard to measure. So who decides what is quality? That's the end of the day. And I think the talk should be about pushing that towards patients. They should decide quality in a sense, but also a big discussion is physician burnout. So we should also be part of the discussion on what to order, how to provide timely care, all those things.
And it's hard to even know what's a clinically effective amount.
Mhm.
from an odds ratio or a risk ratio, how do you get to what's really clinically effective?
I guess it would be based on the outcome you're studying. So, in Farxiga, Jardiance, these SGLT2s, heart attack, that's a pretty big outcome. So even if the number you need to treat is 1 in 100, I think, Yeah.
But, what's the final outcome for the person?
right.
That's true. But
All the math part is over my head. I'm glad you're here to explain it. So, okay. Any other thoughts, questions? Okay, thank you.